I'm just doing a very quick intro and then giving it over to Karyn Frick, who's going to be your chair today. We have 4 very fantastic speakers, and if you'd like to ask questions, we've disabled the chat for various reasons, so please use Slido. There's some more information at the very end, but you just put Slido into Google, and there's your event code number there. My name is Lisa Galea. And this is our first symposium of the Women's Virtual Brain Health Conference series. We have a whole series of presentations for you. Obviously, we need to thank our sponsors that made this possible. It was supposed to be in person in Vancouver in May 2020, but obviously that can't happen for a while, so we'll have to make do with the virtual event. Because we're hosting this from Vancouver, British Columbia, Canada, I'd like to make an acknowledgement, which is I'd like to acknowledge that we're hosting this event on traditional, ancestral, and unceded territories of the Coast Salish peoples, including the territories of the Musqueam, Squamish, and Tsleil-Waututh nations. And we do thank them for the opportunity to be on these beautiful lands. I know not all of you were on here, but happy to share pictures of it later. So as I said, please follow the conversation on Twitter if you'd like, using the hashtag WHSS2020 and Slido code 56030, and Karyn will be moderating the questions. So with that, I'm going to stop sharing my screen so that Karyn can introduce their first speaker.
Okay, thank you so very much to Lisa for putting this together, for all of our speakers, and to all of you for joining us today. As Lisa said, I'm Karyn Frick. I'm a professor at the University of Wisconsin-Milwaukee, and I'll be speaking in this symposium, this series later in the spring. But for today, I have the absolute delight to introduce each of the speakers and hear about their fantastic work. So our first speaker today is Dr. Gillian Einstein, who is the Wilfred and Joyce Poslin's Chair in Women's Brain Health and Aging and Professor of Psychology at the University of Toronto and Guest Professor of Gender and Health at, I can't hope to pronounce this correctly.
Linköping.
There you go, University in Sweden. She's also an adjunct scientist at the Women's College Research Institute at the Rotman Research Institute in Toronto. She's a board member of the International Gender Medicine Society, chair of the Canadian Institutes of Health Institute of Gender and Health Advisory Board, and a founder of the Canadian Organization of Gender and Sex, or COGS, Research. She's a lead of the Women's Sex, Gender, and Dementia Cross-Cutting Program of the Canadian Consortium on Neurodegeneration and Aging, and has served as a temporary advisor for the Women's Health Organization on female genital circumcision / mutilation / cutting, and has numerous honors, including being named one of the 20 Canadian Brain Research Stars from Brain Canada, the May Cohen Lecture in Women's Health, invited member, as well as CIHR College of Reviewers, the Lawrence and Nancy Golden Memorial Lectureship in Mind and Body Medicine. She's also been recognized and profiled as a leader in women's health in Ontario by the Ontario Women's Health Network and as a feminist voice in psychology. She's also been profiled in Psychology's Feminist Voices and has published on Alzheimer's disease, vision, sex differences, female genital cutting, and estrogen's effect on aging, pain, sleep, memory, and mood. Her current research studies the effects of ovarian removal on women's memory and brains at midlife, with a focus on how early loss and estrogens play a role in women's higher risk of Alzheimer's disease. She also studies cognition in trans individuals and how different cultures shape the nervous system. Her broader interests encompass aging, memory, and long-term effects on hormone treatment, and the bridge between our scientific understanding of the nervous system and larger concerns of having to do with self-identity, feminism, and the nature of bioscience. The overarching question of this research is how do both sex and gender mediate women's brain health, which is why we're all here today. So please join me in welcoming Gillian Einstein.
Thank you very much, Karyn, and thank you, Lisa, for inviting me, and thank you all for being here. And it's really a treat to be able to speak with this esteemed group of women. I'm going to share my screen with you now. Share. And sorry, let's go to slideshow. There we are. My talk today is called The Many Menopauses. The Many Menopauses and Oophorectomy in Middle-Aged Women. And let's see how I go forward. Are the changes early brain aging? A question that I'm definitely thinking a lot about, and I know many others are as well. And you can just see some of my affiliations already mentioned below. So I have no disclosures to make. And the plan today is to first talk about the many menopauses, and then talk about menopause prior to the age of 50, zeroing in on women with the BRCA or breast cancer mutations, and asking what are the cognitive and brain changes in midlife in those women who have something called a bilateral salpingo oophorectomy, and then are the changes early brain aging. And I want to apologize to Karyn and Kajal, who have probably already heard most of this talk at another meeting, but in any case. So first of all, menopause, which I put quotation marks around, covers a host of E2 reducing factors. We say women are in menopause, but there are many different types of menopause. Women can go into menopause because of chemotherapy, because of the adjuvant therapy, because of premature ovarian involution, because of other endocrine disorders, oophorectomy, and of course, the one we think about all the time, aging. However, those first 5 may happen long before a woman is aged, may happen when she's in her early and midlife. And these are important things to consider. So all E2 reducing factors really need to be considered when you're studying women. The North American Menopause Society and the Endocrine Society guidelines actually divide menopause into 4 types. And even those of us who work with women who are in menopause don't often use these terms. So the first type is spontaneous menopause, and that's what we think of most often as menopause. It's women who are greater 50 or greater, who have ovarian function slowly change until they're no longer making vital follicles. There's early menopause, which is between 40 and 45 years, and that's the absence of menses with no clinical reason. There's premature, which is less than 40 years of age, and under this comes premature ovarian involution, which is sort of the waxing and waning of ovarian function. And the 4th type is induced menopause, and that is due to, could be chemotherapy, could be hysterectomy, leading to ovarian dysfunction, covers oophorectomy and bilateral salpingo oophorectomy, and ovarian ablation via radiation. All of these are menopausal types. And once you realize that, you have to start asking yourself, should we be including all of these different types in one category, especially when we're studying cognition? So they all have distinct hormonal changes leading up to and after menses sensation, and each has unique health and cognitive consequences. So we looked at what happens with menopause and cognition, and we found when we looked at the literature in 1 year, 2016, after the NAMS and Endocrine Society had come out with their guidelines, that there were many different types of studies. So an undifferentiated study to our mind was a study in which there was no information at all on menopausal type or time since menopause. There was demographic differentiation of menopause, which would include some descriptive information, but it did not consider these different types of descriptions in the analysis. There was partial differentiation of menopause type, where they would talk about the type of menopause, the age at menopause, or time since menopause, and would account for some of these in the analyses, but not completely. So for example, an article that considered the age at menopause and used it in the analysis, but not the type of early menopause. And then we had some studies that had full differentiation, which would report on the different menopausal type and include those in the analysis, or would only study one menopausal type. So when we looked at the literature, first of all, we found 50 studies in 2016, and 15 of those were RCTs, and 35 were observational. And here you can see that of those, most of them were undifferentiated. And when we look at just the percentage of undifferentiated and differentiated and demographic, et cetera, we see that most of the pie is taken up with undifferentiated types, just that is putting everybody in the menopausal category and not telling or separating out the data analysis by type, and 9 differentiated. And those 9 included 7 observational studies and 2 RCTs. So this is a very interesting example, actually, of where clinical research actually lags behind clinical guidelines. Usually the clinical guidelines lag behind the research, but it's just the opposite in this case. People were not paying attention to the clinical guidelines. So just to give you an idea of how great it is when they're fully differentiated, there are clear cognitive effects, including detrimental effects on memory, when the menopause type is differentiated. Kajal had a paper that did this in 2016, and Jacobs et al. Had a paper that differentiated this in 2017, or I guess it came out first in 2016. But the results show that in general, menopause remains for many a monolithic and uniform process. So if we look at induced menopause, and prior to what I call now spontaneous menopause, it's correlated with decreased verbal memory function, if not estrogen replaced for 3 months post-oophorectomy, and this was shown by Barbara Sherwin, and 17-beta estradiol replacement in her papers improved verbal word recall after 2 months of treatment post-oophorectomy. It's correlated with decreased verbal memory, as well as many other types of memory in the study by Farag. And the age of oophorectomy is correlated with increased all causes of death and dementia risk coming out of Roca's group. So in induced menopause, the earlier the menopause is, it leads to a steeper slope of cognitive decline. And this is work done by both. And you see here that if menopause is after the age of 49, there's a relatively gradual slope, whether the menopause is due to oophorectomy or not. Natural menopause actually has a slightly steeper slope here, but the steepest slope of all is for women who have their ovaries removed prior to the age of 38. Their increase in a global measure of the burden of AD as well when the brains come to autopsy, increased numbers of plaques and increased numbers of tangles in the brains of women who had their ovaries removed or went into menopause prior to the age of 38. Now, for induced menopause, imaging of bilateral oophorectomy, and I believe this is also Kajal's work, imaging of women with bilateral oophorectomy at the average age of 46, when you image at the age of 63, when they would be naturally in menopause, the women have smaller amygdalas, thinner parahippocampal entorhinal cortices, entorhinal white matter fractional anisotropy is lower, but there's no difference in the Pittsburgh compound measure of plaque burden in PET, and no difference in cognition in these women between them and women with spontaneous menopause. And this is in another study, they showed that sleep in women with bilateral oophorectomy at the later ages, at age 59 and 60, they have worse sleep duration, worse sleep efficiency, and more insomnia. So there are many menopauses, and the risks and treatments may vary depending on the type. There are still studies that treat menopause as a monolithic category. Induced menopause prior to spontaneous menopause has long-term detrimental effects on cognition and brain. And we need to be clear about why women in our studies are in menopause. So then we ask, what happens in young women with bilateral salpingo oophorectomy-induced menopause. So they start with oophorectomy, hormone levels decline. There are other risk factors that should be considered, like ApoE4, sleep disturbance, inflammation. How does this lead to brain changes, decrease in hippocampal cortical volume and prefrontal cortical thickness, working memory, etc., and cognitive changes? We assume there'll be synapse loss, plaques and tangles at some point out, leading to severe cognitive impairment and dementia, and that this can be studied at both the neural and the cognitive levels. And we need to be asking, when we're doing this, what's the best time for intervention? So we're studying the women shortly after they've had bilateral salpingo oophorectomy. We're not waiting until later in life. So for the group that we study, they carry the breast cancer mutation, and this leads to a higher likelihood of breast and ovarian cancer. They are recommended to have both their ovaries and their fallopian tubes removed before the age of 35, actually. And most of the oophorectomies now done are because of this. It's recommended before the age of 40. It leads to an 80% reduction in the risk of dying from ovarian cancer, 56% reduction in the risk of dying from breast cancer, and 77% reduction in risk from dying from any cause. And so now women are doing this for prophylactic reasons. Many of the women who have their ovaries removed have not had breast or ovarian cancer before they have their ovaries removed, interestingly enough. And for many of them, they're healthy at the time of testing. So we're asking what happens to them, what happens to their cognition, and what are the prefrontal cortical and hippocampal changes in these women, regions that are rich in estrogen receptors. We're doing neuropsych, we're doing imaging, we're looking at sleep with home sleep monitors. Some women are on hormone replacement of 17-beta estradiol plus progesterone, and some are not. The first study I want to report to you is the cognitive changes. This is primarily led by Nicole Gervais, but April Au and Elizabeth Baker Sullivan, actually everybody in my lab has participated in testing and doing the cognitive testing as well as imaging. We look at episodic memory, we look at verbal fluency, recollection of familiarity, spatial memory, and spatial working memory tasks. So the first thing that we notice that happens to these women is that BSO reduces 17-beta estradiol and progesterone metabolites as measured in urine. And here you see the women with BSO have the lowest amount of both progesterone and 17-beta estradiol metabolites in urine. The women who are on hormone replacement have higher levels, some of them not significantly different from age-matched controls. We look and we see that BSO reduces episodic memory. It reduces verbal memory recall, and that the women who are taking E2-based therapy don't seem to be significantly different from either the age-matched controls or their BSO compatriots. But women with BSO are significantly different in paragraph recall from the women who are their age-matched controls. So they're the same age, but they have their ovaries. BSO also reduces working memory, and these are in some our largest effects, in fact. We see that age-matched controls, the women with BSO are significantly different from age-matched controls on digit span backward. They're also, significantly different in a task devised by Elizabeth Hampson, spatial working memory, both on trial 1 and on trial 2. They're not significantly different. Well, let me just say that the women who are taking hormone therapy are somewhere between the women who are not with hormone therapy, and also their age-matched controls. We see that the hippocampus is also significantly different. Left hippocampal regions, including dentate and CA2 and 3, are smaller. And those who are taking estrogen therapy don't have a significantly different, anything significantly different in their hippocampus. So Nicole Gervais has done actually manual segmentation to see these differences in these subfields. And we see that, yes, women with BSO are significantly different from age-matched controls. They're not, however, significantly different from women with BSO taking E2, and they're also not significantly different from spontaneously menopausal women. What happens to sleep? Well, sleep is disrupted. Right now, looking at their polysomnograms and preliminary data, we see that slow wave sleep is disrupted in the women with BSO compared to age-matched controls. Sleep latency, time to get to sleep, is significantly different from age-matched controls, and arousals are different in women with BSO from their age-matched controls. And interestingly, sleep disruption correlates with the smaller hippocampal volume. So you see here, whether or not the women are taking E2 or whether they're age-matched controls, whether they're spontaneously menopausal women, their poorer sleep is correlated with smaller dentate gyrus CA2-3 volumes. Finally, we see, well, not finally, but we also see that working memory changes continue over time. So they're not just at the first time of testing, but when we test the women twice, and then we test them 3 times and sometimes 4 times, they actually have steeper declines if they are not taking 17-beta estradiol. So these are the declines at low times post-oophorectomy and at high times post-oophorectomy, longer. You see that the women who are not taking 17-beta estradiol therapy have steeper declines with time post-oophorectomy. And when we divide those times post-oophorectomy by half a year increments, we see that most of the increase in spatial working memory areas and in digit ordering task errors is after 5 years post-oophorectomy. So this suggests that if we want to intervene, the time to intervene is probably before 5 years post-oophorectomy. Sorry. And some other data that we are looking at now are data looking at the Sperling face name association task. When we look at the behavioral data of face name pairing, we see that women with BSO are no different in remembering the face name pairs than women with BSO taking hormone replacement, than women who are in spontaneous menopause. So the behavioral correlations are no different. Their percent accuracy is the same. But when we start looking at the hippocampus and brain activation during face name recognition, we see that the women who are taking hormone replacement are doing better than the women who have a BSO but are not hormone replaced, and then the women in spontaneous menopause. So there are brain changes that are not reflected in their behavioral performance. And when we look at the region that seems to be the most affected, it's right hippocampus. And this work is being done by Alana Brown. So to sum up, with respect to the many menopauses, studying menopause is really important to clarify the type. You can see what kind of data we get when we study only one type. Performance decrements we see in spatial memory prior to age 48. There are performance decrements in episodic memory. The right frontal cortical volume decreases. Anterior hippocampal volume decreases, and sleep quality worsens. I'm sorry, I forgot to, I left out the data on frontal cortex because we didn't have time. But are these changes early brain aging? I still think it's an open question. So far, what we've seen is that the women look the same as spontaneously menopausal women when we compare them, the women not taking hormone replacement. Only it's 10 years earlier. Hippocampal volume, the spontaneously menopausal women are not significantly different from the age-matched controls. Again, so I think we're going to have to start doing some things to see if what we're seeing is different. But right now, it looks like earlier aging, about 10 years earlier. So I want to thank my students and my collaborators, as well as the referring MDs. I want to thank the funders of this research, and I want to thank you very much for your time, and let you know that the Canadian Organization for Sex and Gender Research is currently planning its second meeting, and we'll let you all know when that's up and ready. Thanks so much for your attention.
Wonderful. Thank you so much, Jillian. That was a really fascinating talk, and it's engendered quite a few questions. So we have several in Slido, and I know that Farida Sarabji has a question as well. So let me just start with Farida.
Thank you, Karyn. Jill, that was a lovely talk. I have a question for you, and basically I'm asking for your thoughts on this. You made a very good point about the different kinds of menopauses. That's something we haven't been paying attention to. But bringing it down to the BSO population, I wonder if you've looked to see what was the proximal reason for the BSO and whether that has in any way changed the outcomes or is a covariate in what you're seeing?
Yeah, of course, that's a great question. And of course, these are women who have a high risk of cancer. So as you might suspect, most of the women who are on who are taking hormone therapy did not ever have cancer. But some of the women who are not taking hormone therapy did have cancer. So our inclusion criteria included no chemotherapy, adjuvant therapy for at least 6 months prior to testing. And we did do, I didn't include the slide, but we did look at the performance of the women with BSO and no hormone replacement, dividing them into women who had had chemotherapy and women who had not had chemotherapy. And we looked at spatial working memory, logical memory, and digits backwards. And we saw no difference in those two groups. So I was surprised, but there you are. We saw no difference, and maybe it's because we waited. A lot of people, there is some literature showing that while chemotherapy may change cognition during chemotherapy, women may recover some cognitive performance after chemotherapy.
Right, and
so I think that's a great question. And then in some of the changes over time, we controlled for chemotherapy, and actually we controlled for chemotherapy in all of our experiments, even though we showed that there's no difference between the groups.
Right, that maybe a good segue to one of the Slido questions here about chemo. So is there evidence for additive effects on cognitive decline for women who have BSO due to malignancy plus chemo or radiation exposure?
Well, no, we don't see that.
Yeah.
So we might not see it because none of them are currently on chemotherapy.
Chemo. Right, right.
And sometimes that gets forgotten. You know, you plan an experiment and you think, oh, it's going to be the perfect experiment. You know, the Women's Health Initiative has scared everybody away from hormone replacement, and so nobody will be on hormone replacement. Well, here we are in Canada, and even back in 2018, 2016, people were being given hormone replacement.
Mm-hmm. Right, okay. Another question is, any idea why errors increase at 5 years? And does this have to do with the dose of estradiol therapy or time initiated?
Another great question, and we don't really have enough people in our groups to be able to answer that question. All of the women had hormone therapy initiated within a year. The women who had who had hormone therapy had it initiated within a year. And we actually left out, we exclude people who are ever users. So people who had it once upon a time, we actually exclude them because we're very unsure because of the literature we don't know whether having it once upon a time is the same as currently using it, or whether it's the same as never having it.
Of course.
And I'd love to hear from others about what they think about that.
Yeah, I mean, that's always a conundrum. You never know how to handle that. Another question is, you mentioned that often estrogen therapy does not help protect against the effects of BSO. Would this differ based on when the therapy is started? And based on your data, I would imagine so, right? You said there's a window within 5 years. I
think so. We have some really interesting, very preliminary data of women before they've had their ovaries removed, testing them, and then testing them after. And if you look at the group data, group differences data, there's no difference because they're all on hormone replacement. That's just the practice guidelines now. Everybody's on hormone replacement. But if you look at the individual people, some of them are doing worse, even though they're on hormone replacement.
Right.
So I think there are going to be some people for whom this is not necessarily a silver bullet. And then, of course, there are other people for whom it's counterindicated. So I also think it's really important for us to be thinking about lifestyle interventions as well.
Good point. Yeah, absolutely. Jill, I think we've run out of time for questions, and so I want to move us on to Farida. Thank you for a fascinating talk, a group of women that so often gets neglected in our studies of menopause. Farida, I'm going to ask you to start sharing your slides. Farida.
I'm here.
Yeah, okay. I'm sure it was just there's always that delay.
Yes.
When you're getting to respond. So I'm delighted to introduce our next speaker, Farida Sorabji from Texas A&M. Dr. Sorabji's research program focuses on brain-immune interactions regulated by estrogens and its implication for neuroinflammatory disease such as stroke in women. She's also interested in estrogen's interactions with other endogenous and environmental endocrine mediators, including vitamin D hormone and the peptide hormone insulin-like growth factor, or IGF-1. Her current studies use an animal model to examine age and sex differences in recovery from stroke, focusing at the cellular level on endothelium and astrocytes, which are the principal components of the blood-brain barrier. At the molecular level, her team is examining sex and age differences in miRNA, MicroRNA, and epigenetic markers with a view to developing biomarkers for disease and uncovering new therapeutic targets. Today, she'll be discussing menopause, hormone therapy, and stroke from her middle-aged female rat model.
Thank you very much for that, Karyn. And also thank you to Lisa and the Women's Health Group there at UBC for this invitation and putting together this symposium. So I'm going to be talking today mainly about our very basic science work. So it's going to be kind of a shift of gears from what Dr. Einstein just told us about. And I want to start with my acknowledgements. Particularly, I want to acknowledge Amrita Salvamani, a former postdoc in the lab, MJ, another former postdoc, Aditya, former graduate student, Shivani Pandey, and then two current members, Yamuna and Katharesh, as well as our collaborators and our funding. And as most of our lab confabs usually take place around food, here is a part of this group. So I want to give you a little background about stroke. Stroke is a leading cause of long-term disability outside of war, and it is also among the leading causes of mortality. And I have a few statistics over here for North America. Stroke kills about 140,000 Americans every year. That's 1 out of every 20. In Canada, that is 7% of all deaths. Someone in the US will have a stroke every 40 seconds, and every 4 minutes, someone will die of a stroke. In Canada, every 7 minutes, a Canadian will die of either heart disease or stroke. So this is a major problem in terms of health crises. And the part of this problem that I'm very interested in is actually summarized in this slide, and that is the sex differences in stroke. In women, stroke is the 3rd leading cause of death, whereas in men, it is the 5th leading cause. Many more women will have a stroke every year as compared to men. They're more likely to be disabled 3 to 6 months after stroke, and they will account for 63% of US deaths. In 2015, this was 58% of US deaths. This graph over here very nicely illustrates the fact that this sort of biased stroke risk in women is very clearly tied to age. What you're looking at over here is a graph where the x-axis shows you age in years and the y-axis shows you prevalence. So the number of females with a stroke at the time versus the number of males. Anything below 1 would obviously mean that women have fewer strokes. Anything above 1 would mean that more women have strokes. And it's worth noting that at the 45 to 54 age range, fewer women have strokes. And as you get towards 65, 75, and 85, many more women will have strokes. But the first time at which the risk becomes virtually equal to that of men is at 55 to 64, which, as you might suspect, is clearly tied to a major event, a major hormonal event in women's lives, the menopause. And I want to show you a graph that tells you why this might be such a crisis. What this graph shows you on the x-axis is time in decades, or in centuries rather, and age in years of menopause and life expectancy. So menopause is essentially between 50 and 52 years of age, and that has not changed for 100 years. Whereas in terms of life expectancy, which is shown to you in the complete line over here, has actually risen dramatically over the last 150 years. So at this point, women can expect to live at least a third of their lives after menopause, which is an estrogen and ovarian hormone deficient state. This adds to the problem of stroke because, as you see in this graph here, and I apologize for how small it is, this is the proportion of population by age that will get a stroke. So stroke is fairly rare in young people, and it starts to ramp up after 50 and 60. And these are the stroke-prone years. And this is where women's longevity intersects with the risk for stroke being a disease of the elderly, resulting in many more women that are likely to have a stroke, likely to have a severe stroke, and not recover as well. The association between menopause and cardiovascular risk is shown very nicely in this graph over here. This was a sort of a meta-analysis for cardiovascular disease and stroke. And essentially, it ties very nicely to the age of natural menopause. I apologize for my trigger-happy mouse over here. The earlier the menopause, the higher the risk of stroke. And the later, the more likely you are to have stroke with the natural incidence that occurs in that particular age category. So there is clearly an association between menopause and the change in ovarian hormone availability and cardiovascular risk. So the question naturally rises, well, if women were given hormone therapy, would that decrease their risk for stroke? And I'm summarizing years of work and several excellent studies, both in terms of primary prevention as well as secondary prevention of a stroke in women who were prescribed hormone therapy. And the results are not very encouraging. In the case of secondary prevention, shown over here in the HER study and the WEST study, it does not really alter a woman's chances of having a second stroke if she's already had a first stroke and is on hormone therapy. The Women's Health Initiative study, which was looked at primary prevention for stroke, they found that it actually did not help. And in the case of any stroke, that is both hemorrhagic and ischemic, it actually increased the incidence of stroke in the population that took hormone therapy. This study is now 15 years old. Well, it's 20 years old, but data is still rolling out of that study. And as many of you might recall, it led to a turmoil in terms of decision-making for women and their healthcare providers about hormone therapy and what risk factors should be taken into account. But it was also a huge surprise to basic science researchers, because a lot of the basic science work that had focused on stroke and hormones had actually shown that estrogen was neuroprotective. Now, I want to make a very important point before we launch into the preclinical data, and that is, in the preclinical data, we cannot assess risk. What we can assess is stroke severity. So I'll be showing you a lot of pictures of infarct volume, that is the amount of dead tissue as a result of stroke. The larger the amount of dead tissue, the more likely you are to have worse outcomes. So in the preclinical studies, many laboratories, including mine, but led by work from Jim Simpkins' lab, as well as Phyllis Wise's lab and Patty Hearn's lab, had shown that mice or rats who were oophorectomized and given either oil or estradiol, you were likely to see a much better outcome from stroke in the animals that received estradiol. And what do I mean by outcome? What you're looking at over here is a slab of tissue that was stained with TTC. It's usually a red color, which you'll see in other slides. This area over here that looks whitish gray is dead tissue. So the space occupied by the dead tissue is certainly smaller in these estradiol-treated animals. This led to the idea that estrogen was neuroprotective for stroke, and consequently that hormone therapy at menopause would decrease stroke severity, if not incidence. What I want to point out here is that virtually all these studies were done in a 3 to 6 month old rat or mouse. For those of you who are not preclinical researchers, this is a mouse or rat that is in the prime of its reproductive life. These are animals that are normally cycling through the estrous cycle, which is about 4 to 5 days. It resembles in many ways the menstrual cycle in young women. And the model is to oophorectomize them, remove both ovaries, and then replace with your drug of choice. This discordance was very surprising, but a few years before the WHI study, my lab had become very concerned about the model that we are studying in terms of stroke and hormone treatment. So this is the most typical mouse. You use an adult animal that cycles normally, that has cyclically high levels of estradiol and progesterone and low levels of FSH, follicle stimulating hormone. What we opted to study instead was a rat that would most closely resemble a menopausal female. And I use those words very carefully because rodents do not experience menopause. They become acyclic, that is, they no longer go through all of the 4 stages of the estrous cycle. our reproductive senescent animals are 9 to 12 months of age. So they're only a few months older than our young females, but they are acyclic. They were successful breeders. They are no longer successful breeders. They are, in a sense, retired breeders. Their estradiol levels are so low that we can't measure them usually. They have low levels of progesterone and elevated levels of FSH. In many ways, this resembles the menopausal profile. And so we use this model to ask several questions. And as the title of my talk says, what have we learned from this middle-aged rat? So the first thing we asked is, we know that stroke outcomes are worse in older women as compared to younger women. Younger women get fewer strokes. They tend to recover fairly well. Can we replicate that in this animal model? And the short answer is yes. Here are pictures going from rostral to caudal of the rat brain. These are 2 millimeter thick slabs. And this yellowish white area is dead tissue. As you can see, the amount of dead tissue after a stroke in a middle-aged female is significantly higher than that of a younger adult female. Again, 5 to 7 months here, and this is about 10 to 12 months for most of our studies. This is quantified here as infarct volume, and we also do sensory motor tests and neurological scores. This is very similar to the kind of diagnostic that a patient would get if they came into ER with a stroke, a suspected stroke. So their outcomes are worse. So the first thing we learned from them is that stroke outcomes are worse in middle-aged females as compared to adult females. The second thing that we asked is, would estrogen treatment have beneficial effects on stroke, as I showed you earlier, on this middle-aged group as it does on the young group? And this is the first surprise we came up with. So here is our panel that I'm going to show you on the effect of estrogen on adult females. Here's an intact adult female. The stroke is fairly small. Here is an oophorectomized female. Look at the amount of dead tissue over here. And this is a age-matched female that got estradiol after the oophorectomy, but much before the stroke. And you can see there's virtually no stroke to be seen over here, no infarction to be seen. If we quantify just these two groups, the amount of infarction is so low in the estrogen group. So we saw what Jim Simpkins, Phyllis Wise, etc. have reported. And then we looked at this middle-aged female. Here is what the intact female looks like. I've already told you the stroke is much worse in the intact middle-aged female. When we oophorectomize them, we actually see, and this is surprising, somewhat less infarction. And when we give this animal estradiol, same dose, same length of treatment, and same route of administration, we make things worse. So estradiol treatment is actually neurotoxic to this middle-aged group. I'm not showing you data on their behavioral outcomes here in this slide, but I will a little later. Their behavioral outcomes are similarly bad given the extent of the stroke here. So essentially, the conclusion from these studies was that in adult females, estradiol decreases infarct volume, but in our middle-aged females, it increases infarct volume. So the second thing we learned from this model, that estrogen treatment is not neuroprotective for stroke in this animal. This has led to a almost 8 to 10 year effort in my laboratory to look for other neuroprotective factors for this particular demographic that is most stroke prone and is likely to have poor outcomes. And we looked at many things, including epigenetic modifiers that I'm going to tell you a little bit about. The epigenetic modifier that we selected were microRNA. These are small, non-coding RNA, and they tend to act like translational repressors. They prevent proteins from being formed because they attach themselves to the 3' untranslated region of coding RNA, and they prevent that RNA from becoming protein. Why did I select them? I selected them partly because of a hangover from estrogen. Estrogen is a truly powerful hormone. It affects many systems in the body, And when it doesn't have receptors in a particular organ, it affects the blood vessels and therefore affects the functioning of that organ as well. MicroRNA are similarly powerful. They're expressed in every cell. They're even found in body fluids like blood, like saliva, tears, semen, etc. So they have the ability to end up in any particular target organ. They're so small, they can enter cells quite easily. And they actually have the ability to affect several targets. A single microRNA will have several hundred targets that it can affect. So we use this to identify a microRNA in the brain that we thought might be protective. And this microRNA is called LET7F. We use the antagomer for LET7F. And in young females, we actually found it was quite neuroprotective. We were pretty excited about this. So we looked in males. It had no effect in males. And we thought, well, there are a couple of ways in males and females are different. Certainly chromosomal sex, which we didn't have the tools to manipulate, and then gonadal steroids. So we oophorectomized our young females and asked, would it still be protective? It has no effect. So clearly it's interacting with the hormonal environment. And then finally, we looked at the group that we were most interested in developing a therapeutic, and that's our middle-aged female rats. And there, to my great disappointment, it was toxic. So in a sense, we had actually found another estrogen. I'm being flip over here, but it didn't really help these females. We pursued the idea of epigenetic modifiers because they are truly in a position to exert a lot of effect on many organs. But this time, what we did was we looked at a different approach. Because although stroke is a problem for the brain, your recovery from stroke will depend on your vascular system, your immune system, and other endocrine organs. And that brought us to another microRNA that we thought had potential. And in this one, what we noticed is that animals that have small infarcts have high levels of this microRNA. So we gave them an antagonist and we made it worse. So we thought we have some mechanistic potential here. We gave it to our middle-aged females and we saw infarct volume was reduced. And then finally, we gave it to our males and we saw absolutely no effect here again. So the caution is that with stroke therapies, we have to be ready that not everything will work effectively. It may work in one sex and not the other, one age group, but not the other. And this has been shown by other labs as well, including Dr. McCullough, who is looking at cell death modifiers, and they also see sex-specific effects. So the third thing we learned is that some drugs will work in middle-aged female animals, but not all of them. The next thing we asked is, yes, we now have a protective microRNA for this group, but the reality is we're only looking at short-term consequences like 5 days after a stroke. It improves a few things, but what a patient really cares about is, will I get back functionality in my limbs, in my sensation, in other aspects of daily living? So what are the long-term impacts? And in a rat, sadly, what you find is that in terms of sensory motor problems, they recover after a while, despite your treatment. So after 60 to 100 days, the control and the treated group are really no different from each other. So we began to ask the question, we should be looking at the long-term neuropsychiatric changes, and specifically things such as post-stroke depression and post-stroke cognitive impairment. Stroke is actually one of the leading causes of dementia. Certainly vascular dementias, but also in AD, lacuna infarcts are seen in brains of AD patients. So it does have the potential for very long-term effects. So we asked the question, we should be looking at these long-term effects. And I'm going to show you a couple of slides very quickly because this is published work. We looked for post-stroke depression. Yes, our animals do exhibit post-stroke depression. We are able to ameliorate some of that with this microRNA that we use in the context of effort-based sucrose preference and in social interaction. Depressed animals actually just stop interacting with conspecifics. With our treatment, we were able to show that interaction proceeded normally. We did the same thing with the cognitive task, which is a Barnes-Maze task. We actually measured this 6 months after a stroke. And we were able to show that, yes, stroke does result in cognitive impairment in our middle-aged females, and that this treatment ameliorates this cognitive impairment as well. So the next thing we learned is that in our middle-aged populations, we can replicate some of the long-term consequences of stroke in terms of depression and cognition, and that one of our microRNA treatments is effective against that. And the last thing I want to talk about is changes in the gut-brain axis. As I've told you, the damage to the brain after a stroke is quite enormous. However, new evidence and new data and new hypotheses suggest that although a stroke occurs in the brain, several organs are involved, including the gut. And we asked the question, what are the changes in the gut after stroke? So here's what the brain looks like after a stroke, and here's what the gut looks like. Since there might not be gut biologists here, I'll spend a minute in explaining this. This is a cross-section of the lumen of a gut. These are the villi. This is the crypt over here. In a sham animal, you see a nice little layer of crypts, and then you see these generally pointy villus structures. After a stroke, just 2 days after a stroke, and in fact even hours, the crypt hyperproliferates, and these villi start to degenerate. They no longer have this nice pointed appearance. They've actually collapsed. And I want to show you a picture that was very dramatic, especially for me as a neuroscientist. This is what happens to the gut in terms of the gut-blood barrier. The barrier is, we tested the barrier by looking at a tight junction protein. In a non-stroke female, you see these very nice little labeling of tight junction proteins in the interepithelial junctions. After a stroke, they're just gone. They're completely damaged. So the stroke is a very early responder, the gut is a very early responder to stroke. And one of the things we're doing is looking to see how we can repair the gut to improve the brain. And we had a paper last year that showed that if we transfer the fecal microbiome from a young female to a middle-aged female, we can improve her outcomes for stroke. That is where we are headed next. So the last thing we've learned from this model is that the gut microbiome is a critical regulator of brain health, and transfer of the microbiome will affect stroke. So I want to end over here by acknowledging not only my lab, but a very important part of our research program, which is the middle-aged rat. Thank you very much, and I'll be happy to take questions.
Thank you so much, Farida. Unfortunately, we're running late, so we have time for just one question. But we will, we're trying to figure out currently if there's a way that we can have Farida answer questions offline. So, but I'll ask one, what do you think makes estrogen therapy neurotoxic for menopausal females, i.e. reproductively senescent mice or rats?
Okay, so we've been chasing that for 2 decades now. If I had an
answer,
I'd patent it. I think the answer lies in several things. One of the things we've shown is that the estrogen receptor cohort changes in these animals. And so now the estrogen is being used by a different cohort of receptors. And the fact that estrogen receptors sometimes collaborate with other hormone and peptide hormone receptors has also been a problem. So estrogen and IGF-1 together can actually increase heterodimerize together with their receptors to achieve neuroprotection. These middle-aged females have not only lost estrogen, but they also have less IGF-1. So it's not just the loss of one hormone, it's other neuroendocrine factors as well, which is why I think it works in young females because they have so much IGF-1 available and other neuroprotective factors. Doesn't work as well in the aging animal because they've lost so much of the neuroprotection. And now the hormone is using the estrogen receptor for some of its more toxic effects instead of being shepherded into a neuroprotective pipeline.
Wow. Interesting. We wonder if some of these microRNAs maybe contribute to that shift.
Mm-hmm.
Yes, definitely. We are seeing a huge shift in microRNAs, and it's very hard to say that the going up or the going down is the problem, because what we fail to take into account is that biology is very clever. There are always compensatory mechanisms that the body is making. You lose estrogen, maybe you increase something else. And,
Right.
and those compensations sometimes, I think, what gets us into trouble by not paying attention to this.
There are always consequences to any change. Okay, well, Frida, thank you so much. Can you please stop sharing your screen so that Neil can get her slides up?
Yes.
Okay. Oh. While Neil is putting her slides up on the screen, I just want to introduce Dr. Neil Epperson, who is internationally known for her unique lifespan approach to women's reproductive and behavioral health in both her clinical and research approaches. As a clinician scientist, her work relates to early life stress and its impact on risk for affective disorders during periods of hormonal change, as well as she also conducts projects relating to cognitive decline during menopause and sex differences among smokers that have been funded by the National Cancer Institute and IMH, the Office of Research on Women's Health, and NIDA. Her work has led to a greater appreciation of the impact of childhood adversity on physiologic responses during times of hormonal fluctuation, as well as gonadal steroid effects on brain and behavior. Her research has been consistently funded by the NIH for more than 2 decades. She's a productive mentor and an independent investigator with more than 200 peer-reviewed publications and presentations. Today, she's going to be talking about relating her work to on childhood adversity to looking at the long-term effects on mood and cognition at menopause. Thank you so much, Neil, for joining us today.
Yeah, and everybody can see my screen. It should be pretty big.
Yep.
Okay, awesome. That's great. I just have a few disclosures, but these do not relate to the information I'm going to be sharing herein. So I want to talk a little bit about childhood adversity and just its overall impact on development and some sex differences that we observe with respect to timing and its impact of these adversities on brain development. And then a lot of people think, well, you know, how common really are these adverse childhood experiences? And I think you'll be a little shocked when you see these data. And then we refer to adverse childhood experiences in most of our research as ACEs, and you've probably heard about these before, but we'll explain what it is that we mean. And then again, I'm really focusing on, you know, as a clinician scientist, I would see a lot of women who could go through menopause and not have problems with mood or cognition. And then there was always this group of women that seemed to have such a great difficulty with this reproductive transition. And I started really thinking about sort of what makes them more vulnerable. And I'm going to show you data that suggests that the impact of adverse childhood experiences on the brain is a potential, really is, at least our data suggests, a causal factor. Now, I think everybody hopes that they are born into the world with a sunny disposition and that you can handle stress and that, you know, whatever comes your way, you're going to be happy. But many of us enter into the world with a little bit more of a pessimistic view, and how we respond to stress really is a lot about what happened in utero, what happened to our parents, preconception, and then sort of our temperament that we bring into the world. So this whole concept of stress, we really focus on preconception for both mothers and fathers. And then again, what happens in programming in utero, and there seem to be sex differences there as well. And then obviously your exposures across the lifespan can differ. And that these really do have impact, again, throughout development, from in utero, parental preconception stress to old age. And what we know from work from Marty Teicher's lab, as well as others, that if you look at the timing of insult with respect to either maltreatment or abuse, neglect, those kinds of issues, that you'll see that early brain structures that are developing very rapidly around the age of 3 and 4. The hippocampus, is really coming online and rapidly developing. And again, it's this concept that whatever part of the brain is kind of rapidly developing at the time of these insults is the part of the brain that is going to be more vulnerable. And so when you've got sort of preteens, you've got these midline structures. And then of course, females have onset of puberty more quickly than males. And so their prefrontal cortex is starting to develop earlier. And again, so as their teen years, it may be a little different for them if they undergo an adversity than a boy at the same age, because of the prefrontal cortex developing and coming online a little bit later, at least in males who are having puberty onset later. Now, when we talk about ACEs, we're really using the definition from the CDC. And again, this is a sort of a general idea. It's not like the childhood trauma questionnaire where you kind of get how often these things happened. But we decided to use this kind of metric, mainly because there was so much data being collected across the world about the impact of ACEs on health outcomes. So the instrument is really 10 questions, 3 about abuse, 2 about neglect. And then there's about 5 questions that really kind of focus on household dysfunction. And from the earliest ACEs studies, as well as ones that have occurred since the 1990s, we know that there's an adverse effect of ACEs on how people behave, health behaviors, but there's also independent effects on health outcomes. Now, again, some of it is lack of physical activity certainly could increase risk of severe obesity, diabetes, what have you. But again, there seems to be also a direct effect on these health outcomes. All right, so how common are ACEs? Well, we know that there's a sweet spot that if you have 4 or more ACEs, that is going to be a very high risk for various types of physical illnesses as well as mental health concerns. Our data that I'm going to show you shows that even when it comes to depression and anxiety and cognitive functioning in women, that 2+ ACEs is a risk factor. But when you have 4+, these are the ones that you're most likely experiencing: emotional abuse, domestic violence, emotional neglect. And again, all of these things are occurring in your life before the age of 18. And if you want to look here, you can see that more men are in that 0 to 1 category, and you actually have almost twice the amount of women in the 4+ category. And then how does this vary across the United States? I don't have these data for Canada. I'm sorry, Lisa and Jillian. But in the United States, if you look across the map, there's about a 3% prevalence of having 4+ ACEs in some of the East Coast areas. But if you go to more rural states, you get into 10% to 12% of individuals polled will tell you that they've had 4+ ACEs. So we know that adversity early in childhood does vary considerably across the nation. So let's focus on how all of this kind of adversity that occurs before the age of 18, how can it possibly still have an impact on the menopause age woman? Well, first of all, we really got very interested in both mood and cognition. Obviously, I'm a psychiatrist, and neuroscience is my area of interest. And as you've heard, menopause can have, particularly in the earlier menopause and loss of our ovaries, that you can have a negative impact on verbal memory. But the questions I had is, again, how much is there an interaction between ACEs, timing of menopause, and whether you're having difficulties both mood-wise and cognitive-wise? So I was lucky to work with Mary Samuel and Ellen Freeman when I was back at Penn on the Penn Ovarian Aging Study as a prospective community cohort of 436 women. Over the course of 14 years, we had more than 3,000 observations on these women. Everyone was enrolled as a premenopausal woman, regular menstrual cycles, no changes, and the vast majority were studied on to the postmenopause. So we initially published that, if you look here at the figure, that as women proceed through the menopause, controlling for things like BMI, education, age at which you went through menopause. And all of these women had intact ovaries. So I want to make that very clear. If you wound up using hormone therapy, or you wound up needing to have an oophorectomy, then you kind of were taken out of the study. So this is solely focusing on women with intact ovaries and no hormone therapy. And you can see that when you get to delayed recall, even in the early transition, you have a significant negative impact on your ability to recall a list of words. Now, we also were very interested in, does ACEs increase this risk of having, here in the blue bars, you can see women who have, the dark blue bars are women who had onset of depression solely in the menopause transition. And you can see that there's quite a few that even meet clinical criteria. But as they go into the postmenopause, their risk of depression actually really drops off. And so we were wondering if these women who really have this depression onset in the perimenopause were more likely to have this because of ACEs. So we basically focused first on the women who were left in the study. We got ACE questionnaires from all of these women. And what I want to really emphasize is that we looked at lifetime depression as well as this incident menopause depression. Again, looking at this perimenopause depression, were early child events interacting with these hormonal changes to lead these women to have greater risk of sort of unmasking the risk of these ACEs on depression. So if you had 2 or more ACEs, you did have an increased risk of major depressive illness in general. And one of the important findings that we had, that if you had prepubertal ACEs, that basically you were more likely to have incident menopause depression. If you had pre versus post-pubertal onset of ACEs, you had a differential effect. So actually, any ACE actually increased the risk for the incident as well as lifetime. But importantly, if you had one prepubertal ACE, so an event that occurred prior to getting your menstrual cycle, actually we went 2 years before you had your first menstrual cycle and defined that as prepubertal, you'll see here that you have some resilience actually to the impact of future ACEs. So there seemed to be an impact on whether you had prepubertal or postpubertal. And again, one prepubertal ACE appeared to engender some level of resilience in these ladies, that they could go on to have additional postpubertal ACEs and not have as great a risk for depression. Then we moved, after looking at a natural menopause population, we wanted to understand sort of what was happening when women were having oophorectomy due to genetic risk for cancer. They completed behavioral assessments like the ACEs, a hospital anxiety and depression scale, and then we gave them not only a subjective measure of their executive functioning, and one of the reasons that I started focusing more on executive functioning than things like verbal memory and more hippocampal recall kinds of tasks is because of the nature of the complaints the ladies were having when they would come to see me, that they really felt like they had a difficulty focusing, sustaining attention, you know, being able to be distracted and keeping their mind on task. And so we assessed using an attention deficit disorder scale, the subjective, and we also looked at objective measures and continuous performance task, as well as a working memory task. So basically, I can tell you that our low ACE ladies and our high ACE ladies did not differ on any of these: age at oophorectomy, time since oophorectomy, and time without hormones, nor do they differ with respect to history of cancer. These are just some of the most common types of ACEs that occurred in the high ACE group. I do want to show you that even in our low ACE group, which is a 0 to 1, this is 2 or more, you can see that in some cases, even in 7% of cases, that they could have their one ACE be sexual abuse. And so that is quite remarkable. But what did we find when we looked at their subjective? So this is their self-report on the Brown Attention Deficit Disorder Scale. You can see subjectively that high ACE ladies, and again, we control for a number of different factors here, had greater overall bad scores, their motivation for work, being able to force themselves to do things, attention concentration, alertness, processing speed, as well as verbal memory. Managing affective interference was not significantly different between the two groups. Now, this is based upon a continuous performance task, and this is a sustained attention task. And you can see here that even on this objective measure, that there is a decrease in performance in the highest group, and there's a decrease in performance on the working memory task, the NBAC task. So because we know ACEs increases the risk of depression, and ACEs were in this study, the women in the highest group had more depression and anxiety symptoms, we wanted to see, is somebody's affective state moderating the effect or mediating the effect of ACEs on these cognitive outcomes? And what you can see that when it comes to the subjective measure, yes, there is a significant mediation of the mood symptoms on how people report their cognitive functioning, but it doesn't explain all parts of the ACE effect. The same thing is here with the continuance performance task, that yes, if you have more negative mood symptoms, anxiety, depression, you are going to perform worse on the CPT. But again, there is still some independent effect of the ACE. And what was really interesting, it is in the working memory task. And if you really think about this as bilateral, dorsolateral prefrontal cortex, middle frontal gyrus, that basically you do not see a mediating effect of mood symptoms on working memory performance. And so we do not understand as of yet why ACEs is having such a negative impact on the working memory task. Now, some of us may wonder about the chemotherapy. That question came up in Jillian's talk. Basically, yes, your total subjective score was higher, but it wasn't significantly for the subjective outcomes. But on the sustained attention task, these women did perform worse if they had a history of chemotherapy. And this is controlling for ACE group. So no matter what ACE group. Now, I want to tell you that most of the ladies in this study on average had had at least 6 to 7 years since their last chemotherapy. So again, this is not in the middle of chemotherapy. This is many years later that you're still seeing this impact. And again, we control for age group, time without hormones, education level, and what have you. So then we started looking at brain imaging. Again, I say we started, I'm making it sound like these were sequential studies. No, these were all ongoing at the same time. My postdoc, who's now a psychiatry resident and colleague, James Lohead and Ted Satterthwaite, all worked to support Sheila and analyzing the data from this particular project. And this is a brain imaging study of working memory in high and low ACE women. So using 3T magnet, we basically were focusing on the MBAC task. And if you're not familiar, you're lying in a scanner. If you look down here at the bottom, you can see the MBAC, there's a fractal MBAC. So basically, a zero back is you're being told in the instructions, press the button when you see this particular fractal. One back is when the fractal matches the one right before it. 2 back is when the fractal in front of you matches 2 places back. And then you get to the very difficult 3 back, which really challenges and pushes the prefrontal cortex like crazy. And basically you're having to remember that this is the fractal you saw 3 positions back. Now this is a little bit of a complicated study design because there's evidence from animal studies that your estrogen state is affected affects not only serotonergic functioning, but early life stress and rhesus macaques is associated with long-term effects on how your brain responds to estrogen, particularly through the serotonergic system. So in any case, we had phase 1. All of these are healthy, cognitively intact, postmenopausal women within the first 10 years of final menstrual period. So that first window, most were on average around 4 years since final menstrual period. And we had them come in, they were all low estrogen. They were not using hormone therapy and could not have used hormone therapy in the previous year. we did a procedure where we tryptophan deplete people. So they take a lot of amino acids other than tryptophan, and then in about 6 hours, that leads to a very diminished state of tryptophan, which is the precursor to serotonin. And there's evidence that in CSF, the serotonin levels also go down anywhere between 60 and 80%. So they do a tryptophan depletion or a sham depletion, and this is obviously order is controlled for. And then they come back, and at the end of these days, they do this working memory task in the magnet. They either then get estrogen or a placebo patch for 8 weeks, and this is 100 micrograms of 17-beta estradiol, and then they come back and do this process again. So again, this is the working memory task. It robustly activates dorsolateral prefrontal cortex and middle frontal gyrus. Our ladies in this study, we had 19 in the low ACE and 14 in the high ACE when all was said and done. And basically, I won't go into all the different ACEs that they had unless you want to ask about that later. So what did we find with respect to their performance on this working memory task? And then what was going on with the blood oxygen level dependent signal? So let's first of all see that basically, when you looked at the task, this is a brain region that was robustly affected in a whole brain analysis. And so we took this and plotted bold signal in that region based upon total ACE score, not the 2+ or the 0 or 1 ACEs, but the total score. And we do see that as ACE number increases, that you get a increase in bold signal activation. Now, what does this say to me as somebody who does functional neuroimaging? Because you can interpret fMRI studies in a lot of different ways. But to me, what this said is that these individuals were activating the prefrontal cortex more just to do as well. Because you can see here that the true positive count, getting to the number right, really does drive the prefrontal cortex, that you have to activate that prefrontal cortex in order to do this task correctly. But then what about the percent bold signal change if you were in a low ACE group or a high ACE group? So the white bars are the sham depletion. So that just means that you had basically you had, and this is the pre, so this is the pre-phase. So all of these women are low estrogen, and during sham depletion, we haven't manipulated their serotonin levels at all. But in the active depletion, you are low estrogen and low serotonin. And what you see here in the low ACE group, that when we tryptophan deplete them, they have to activate their brain more in order to be able to do as well on this task. But now let's just look at this high ACE group. They look completely opposite to the low ACE group. And I think that what really disturbs me tremendously is that in this sham depletion, where they've got normal levels of serotonin, but low levels of estrogen, they're really having to activate this prefrontal cortex to a great degree in order to do as well as the low ACE ladies. Now let's look at what happens in phase 2. So this is that pre-randomization that I was talking about, where they were low on estrogen, and then half the group got placebo and the other group got estradiol. And what you see here is that in the low ACE group, they look with placebo fairly similar. So there's no significant difference if you look at placebo in this group. But let's look at placebo at the sham depletion. And here you see again this really accentuated bold signal. What was very interesting is here when you gave the estradiol. Now we have absolutely no difference either in the sham or in the active depletion between the low and the high ACE ladies. Now, what does that say to me as somebody who's thinking about the impact and the relationship between the early life stress and then how estrogen is impacting the brain? To me, what this is saying is that maybe our low ACE ladies, okay, estrogen is not really impacting how they perform so well. It's also not really impacting the bold signal in the prefrontal cortex, whether we manipulate their serotonin levels or whether we give them estrogen. They're looking pretty much the same. But it's this high ACE group that, it is this high ACE group that I have great concerns about. I mean, it's almost like what this is saying to me is that the high ACE ladies probably do need the estradiol to help modulate what's going on in the prefrontal cortex while they're trying to do working memory so that they don't have to overactivate to do just as well. And then we also looked at something called network connectivity. And I'm just going to very briefly show you this. So that basically, in order to be able to perform this task well, you need to increase within network connectivity in the executive network. So you've got between network connectivity and within network connectivity. And as the female and the male develop and their prefrontal cortex develops, and they become better and better at executive functioning, they're basically tightening up that within network connectivity. And what we found here is that basically within network connectivity was impacted, didn't matter what condition the individual was in, whether it was active or sham. The bottom line is that within network connectivity is significantly decreased in the high ACE individuals. So it may be one of the reasons why they have to work even harder and stimulate that brain region in order to be able to perform these tasks. So ACE is having an enduring impact on executive functioning, the regions in the brain that are important for executive functioning, how they activate under working memory tasks. Also, the network connectivity is altered by ACEs. So what can we do? I will answer that question if people have if people have questions about this, but the bottom line, this is what we have left to do. We have to figure out what we should do. These data need to be replicated, because if it is indeed that women with high ACEs would do better with estradiol, we need to know that. We can measure ACEs, obviously, as women are going into the transition and during the transition and postmenopausally, but we can't change the past. So how do we minimize the adverse effects of ACEs with respect to cognitive performance and mood in the middle-aged woman? I will stop sharing my screen.
Wonderful. Thank you. Thank you so much, Neil. That was a fabulous talk, and there are a number of questions, but unfortunately we're running quite a bit late. So, but the conference organizers are working on a way in which participants can send questions to the speakers and they can answer them so that they can be answered, because there have been so many really great questions that we unfortunately don't have time to get to today. So I want to introduce then our last speaker, Karyn Frick. She is a consultant and professor of radiology at the Division of Neuroradiology, Mayo Clinic, Rochester. She is the director of the Neuroimaging Core of the Mayo Clinic Alzheimer's Disease Research Center, the associate director of the Center for Clinical and Translational Research, KL2 program, and the research director of the Building Research Careers in Women's Health program, the Birch KL2 program. Her research focuses on the neuroimaging, neuroscience, and clinical aspects of aging and dementia, and is integrated with 2 NIH-funded multidisciplinary centers at the Mayo Clinic, the ADRC, Alzheimer's Disease Research Center, and the Specialized Center of Research on Sex Differences, or SCORE. Dr. Kantarsi is a founding member of the Society of Women's Health Research Alzheimer's Disease Network and member of the Dementia with Lewy Bodies Scientific Advisory Council. Currently, she is leading an NIH-funded multi-center program on determining the long-term effects of early menopausal hormone therapy on Alzheimer's pathophysiology. She received the De Leon Prize in Neuroimaging Senior Scientist Award from the Alzheimer's Association in 2018 and was the chair of the Alzheimer's Association International Conference in 2019. She has authored over 200 peer-reviewed publications in the field of neuroimaging in in aging and dementia. And today she will talk with us about menopause and aging and Alzheimer's disease.
Okay, can everybody hear me? And
yes, but I think your screen went from your presentation to go to meeting. 5, which I don't think we really, yeah, there you go. Now you're back. Presenter view and you're ready to go.
Okay. Do you see my screen?
Yes.
Thank you so much.
Thank you for the introduction, Karyn. So as Jillian pointed out, we need to specify which menopause we're talking about. Here I'm talking about the natural menopause and how hormonal influences are on biomarkers of cognitive aging and Alzheimer's disease. So these are some of the disclosures I have. As we heard from animal studies that in the overrectomized animal models, estrogen may influence some of the brain function, connectivity, and health. We see in rhesus monkeys and rodents that estrogen may increase synapse formation and connectivity in the brain, particularly in the hippocampus and prefrontal cortex. There's an influence on beta amyloid deposition through mechanisms of improved clearance, increase in cerebral blood flow and metabolism, and that appears to be interacting with the ApoE genotype, which is one of the most significant risk factors for Alzheimer's disease. Now, from Women's Health Initiative memory study, we have learned that combination estrogen, the oral CEE formulation plus progestin in women who are older than 65 doubled the risk of dementia. However, this did not present in all women equally. Those who began menopausal hormone therapy with already lower cognitive function at baseline appeared to be more vulnerable, and women who received menopausal hormone therapies at a younger age, during ages less than 60, were less vulnerable. So there appears to be an effect on the age when the hormone therapies were instituted. Now, including Women's Health Initiative study and other observational studies, this age effect has been presented pretty clearly. First of all, some of these studies have shown that there may be a reduced risk for cognitive impairment and dementia if the hormone therapies were given to women at younger ages, as you see here in the at the top in the early postmenopausal years, versus late postmenopausal years, where the therapies seem to increase the risk of cognitive impairment and dementia. So these early menopausal years where the hormone therapies may be beneficial to the brain is thought to be a window of opportunity for menopausal hormone therapies. Based on this hypothesis, the timing hypothesis, 2 clinical trials have tested this. First of all, the early and late intervention with estradiol or ELITE trial tested whether early versus late menopausal hormone therapies have any effect on vascular health as well as cognitive effects. Now, they did not see an effect on cognition in early versus late groups. However, they showed that early menopausal hormone therapies have slowed atherosclerosis, whereas late did not. Now, the second study, which we will be focusing more on, is the Kronos Early Estrogen Prevention, or KEEPS trial. In this trial, the early menopausal group was targeted, and menopausal hormone therapies did not show an effect on atherosclerosis. And again, similar to what was found in the ELITE trial, there was no influence on the cognitive change in the menopausal hormone therapy group compared to placebo. So the conclusion from these studies was that hormone therapy given early after menopause did not have an effect on cognitive function at the end of the treatments. Now, one might ask whether women who are in their 50s would show an effect on cognitive function when menopausal hormone therapies are given, and is it too early to see these cognitive effects? So that's where the imaging biomarkers come into play. Now, when we look at the clinical and pathologic progression of dementia, there is a preclinical phase where the pathologic involvement precedes the decline in cognitive function. And in this preclinical phase, which is a long phase spanning almost a decade, even more, there is a gradual involvement of Alzheimer's disease or other pathologies in the brain. And then the cognitive function starts declining after a certain threshold is reached, and then gets accelerated after even a higher pathologic load is reached. Imaging biomarkers that are sensitive to this early pathologic stage are useful for early detection when there is no cognitive changes, and can be used as outcome variables in clinical trials to detect any effect of preventive therapies. Now, I will focus on the KEEPS trial. As I said, this was a trial that was conducted from 2005 to 2009 in 727 women who were aged 42 to 58 years, all within 36 months of last menses. And they were quite healthy. They did not have prior cardiovascular disease events, and they were enrolled in 9 US academic sites. They received treatments of placebo pills and patch or oral conjugated equine estrogen. This was slightly lower than the dose that was given in the Women's Health Initiative study, and also the transdermal 17-beta estradiol, the skin patch. And oral micronized progesterone was given to the active treatment groups, the 2 treatment groups, and 12 days each month. Of course, the placebo group did not receive that. Now, the women participating in the KEEPS at Mayo Clinic, which was 118 of them, were participating also in the imaging study. And the goal was to assess the effects of hormone treatment on surrogate imaging biomarkers of cognitive health. Now, we followed them throughout the KEEPS trial, which was for 4 years, and then we followed them another 3 years for a total of 7 years with imaging and cognitive testing. These are the timelines of the study. As you can see, we had a month zero or baseline evaluation with MRI and cognitive testing, another evaluation at 18, another 36 and 48 months. This was during the menopausal hormone therapies, and then we waited another 3 years to look at the long-term outcomes. Now, I will be talking about longitudinal MRI data as well as cognitive data in this data set. So this is how we calculated whole brain atrophy and ventricular expansion rates. We have looked at the change in the borders of the brain as well as the CSF spaces. And when we calculated the change, what we saw was that the whole brain volume change was declining in all groups as expected, and ventricular volume was increasing. However, the oral CE group showed a greater increase in ventricular volumes compared to placebo. And then after 3 years of waiting, we saw that the whole brain volume change continued to decrease in all groups due to aging, and this difference in oral CE group disappeared, and they did not show any difference from placebo. The cognitive function did not differ between the groups over time. Another biomarker we looked at was white matter hyperintensities. We know that white matter hyperintensities are a surrogate for small vessel ischemic disease. They cause decreased myelination and lower capillary density. And when we calculated the rate of change in white matter hyperintensities, what we saw was that there was an increase in all groups, but oral CE groups had shown a greater increase compared to placebo over the 84 months, 7 years of follow-up. And this was a gradual increase, and really the difference got bigger and bigger as we took our time following these women. We also found that the thrombogenic properties of estrogens, particularly oral CE formulation, may be responsible for this because this correlated with the thrombogenic microvesicles in the blood. Now, we also looked at the cortical volumes over 7 years, and what we found was that the dorsolateral prefrontal cortex change was much less in the estradiol group compared to the placebo. In the CE group, we did not see this effect. So this part of the cortex which was also shown in animal studies, was relatively protected from atrophy in the estradiol group. So in summary, we found greater rates of increase in ventricular volumes in the oral CE group compared to placebo over 4 years, but this trajectory of change was not different from placebo over 3 years after treatment. The women preserved their prefrontal cortex in the transdermal estradiol group more than placebo over 7 years. And white matter hyperintensities both increased in oral CE and transdermal estradiol groups, but this was only significant in the CE group and correlated with the thrombogenic microvesicles in the blood. We found no difference in global cognitive function over 7 years. So we see that there are certain biomarkers that changed over time during menopausal hormone therapies, but kind of stopped changing after the therapies were stopped. So, and others that continued changing. So the short-term effects of estrogen treatment on the vascular system and on brain structure may be different from the long-term effects. And then here's the other study we did on beta amyloid PET, which was done at 84 months, 7 years after therapies. As you can see, beta amyloid pathology of Alzheimer's disease involves the brain's decades before cognitive impairment and dementia. And here we see that amyloid imaging can help us identify these changes. And now here is the data on the oral CEE versus placebo group and transdermal estradiol versus placebo group. We see that transdermal estradiol group is showing response to treatment by showing lower amyloid levels compared to placebo. This is particularly true for ApoE4 carriers. And this is the correlation between amyloid beta and the preservation of prefrontal cortex. There is a really good correlation between the two. And it may be that there is a relationship between the two by, lower A beta levels may preserve prefrontal cortex, or a similar mechanism is influencing both. And this may be through estrogen receptors, where estradiol's influence on the prefrontal cortex and amyloid deposition, maybe through a receptor-mediated mechanism. And it does not seem to be extending to the oral CE formulation. Now, in conclusion, effects of early menopausal hormone therapy on biomarkers of cognitive health differ by formulations and administration routes. The effects seem to be modulated by ApoE4 that increases the risk of cognitive decline and Alzheimer's disease. This has important implications for individualized approaches to prevent Alzheimer's disease in women, particularly ApoE4 carriers, who are the most vulnerable. And we are continuing this study with the KEEPS continuation study, which is funded by NIH, Alzheimer's Disease Discovery Foundation, and Eli Lilly. We are looking at the large cohort of women from multiple different centers, 14 years after randomization, looking at cognitive function, amyloid deposition, tau, and MRI changes. And I would like to acknowledge my colleagues who are part of the KEEPS continuation study and grant support and participants of the study. Thank you.
Thank you so much. I think we actually have time for a couple of questions. I'm getting the thumbs up, so that's awesome. Right, so one of the questions, so there's several questions here. One of them is, what was the effect of ApoE genotype, and did it influence estradiol? Did it influence estradiol findings?
ApoE genotype did influence estradiol findings. I'm very sorry, I went really quick. And we did see the effect only in the estradiol group, interestingly. Now, there may be two reasons for it. Maybe that ApoE4 is really modulating, like a pharmacogenomic effect, the effect of estrogens on amyloid. Or it may be that women are too young to show any effect on ApoE4 negative individuals. So we know that ApoE4 positive individuals accumulate amyloid at an earlier age. So we may be looking at an age where women are going to be responding only in the ApoE4 positive group because they're the ones who are accumulating. And in the ApoE4 negative group, it may be too early to see such an effect. So in this 14-month follow-up study, when the women will be in their late 60s, I am hoping we will be able to answer this question.
Ah, okay. Thank you very much for clarifying that, because I had the same question actually. Another question is, do you think the dose of transdermal estradiol was too low to see effects?
It may be possible. But we will never know unless we do a study with higher dose estradiol. So it's possible that the dose was not enough. I mean, others kind of find solutions of titrating based on women's, baseline hormone levels, particularly for BSO type studies where, before oophorectomy, what was their estrogen levels, and then you titrate based on that for the replacement. But we do not have such a possibility in this study, of course.
Right. Jillian actually had a similar question, which was, well, a follow-up, I guess, which was whether there was a progesterone or a progestin in with the transdermal estradiol.
Yes, but the progestin was given, micronized progesterone was given 12 days each.
Right.
So it's really important to see. I mean, we wouldn't be able to parse out the effects of progesterone versus estradiol, of course, in the study. Both groups are given progestin.
Right.
But it's an important issue.
Mm-hmm. Okay, I don't know where we are in terms of time.
Well, we're 1 minute over, but maybe we can have one quick question for Neil, because we skipped poor Neil. She's still there. I know she has to leave really soon.
No, that's fine. Yes.
One of the questions I remember was, so I just quickly asked again, do you know, did you look in your own data? Obviously you have the ACEs, which I think is an unfortunate acronym. Like, it's not an ACE. It's like, anyway, adverse childhood experiences. How do you look at all in terms of adult stress and how that might interact in a positive or negative way with some of your findings? That was one of the questions, something like that.
We do look at perceived stress currently, and we do have, usually what we get is a trauma questionnaire just about trauma that is across the lifespan. And the bottom line is that, we basically say, okay, well, if in our high and low ACE groups, what is typically current perceived stress? And we haven't so much looked at the TLEQ data. A lot of our ladies don't report a lot of those kinds of traumas. So we've been thinking much more along early childhood adversity and then your perception of stress currently, because obviously highly stressed individuals, they often do, especially in like COVID pandemic times, it's chronic, it's persistent, it's, unclear when it's going to end. So we try to focus mostly on perceived stress, current, and then those early childhood events.
Okay. Yeah, unfortunately, I can't remember. Lisa's got a better memory than I can. I can't remember any of the list of questions.
So I guess I should clarify, our ACE effect is there regardless of current perceived stress.
Right. Mm-hmm.
Just to make that clear.
I have a question for Neil if there's time.
Mm-hmm. Sure, let's try and finish by 10:50.
Okay.
Okay,
The
2 minutes.
question is this, Neil. We're learning about the women with the BRCA mutation that, of course, they all have a traumatic background in that their mothers, their sisters, their grandmothers, their aunts had breast and ovarian cancer, and many of them died. So I'm wondering if that's reflected on the ACEs at all, or if that's a kind of overshadowing trauma that affects this group.
Yeah, it would be collected if the loss of the parent occurred before the age of 18. But loss of a parent 25 to 40 or what have you, no, that would not be part of it. And again, all of these women in that oophorectomy group, you would assume that there's no differential about how many lost a parent versus those that didn't or watched their mother go through chemotherapy and those kinds of things, because we weren't comparing in that study natural menopause women with these women who are at genetic risk. But you're right. I mean, ACEs doesn't take care of everything. It doesn't really assess poverty. It doesn't assess the number of times you might have been sexually assaulted. The reason, again, is it is a very easy to use public health level assessment. You can give it, online. People don't freak out when you ask them these questions, and so they don't have to be there in your office. Where you start getting into the TLEQ and the child trauma questionnaire, you're really getting somebody to share a lot more, and it can be much more difficult to do that virtually or just in a doctor's office.
I appreciate it. I think your work's really interesting. Thank you.
Same to you. Same to everybody. This was great.
I know, I wish we had more time.
I wish there was more time, because everybody is doing such important work trying to figure out, women are at greater risk for dementia, for Alzheimer's disease, and all of you are addressing a different reason why that may be, all of which is extremely important in trying to really piece together why women are at risk and what we can do about it, importantly. Yes. So I want to thank Lisa for putting this symposium together, because these were 4 amazing speakers. And hopefully at some point in the future, we can all come together and in BC or someplace else soon.
Yay.
Lisa, I don't know if you have anything else you want to say about the series or the next.
That would be really great if I had a closing slide with that on there, but we have events every month. I know the next one I think is the 16th of November, and it's actually, I think we had one of the speakers online, I think she still is, Shirley Weir and Patricia Thomas-Say, and they're women's health advocates in the community, and they'll talk about sort of avenues that they've found to drum up support for women's health and for information and for research itself. So, and both my Shiro. So I'm looking forward to their presentations. So look on our website. We'll try and find a way that we can do something friendly, kind of chat way, so that if people had more questions and they want to interact. We're also going to have some mentor networking sessions, and we're going to ask some of these speakers to volunteer their time to talk to some of the trainees too, if they so desire. So I'll get in touch with you guys about that. But thank you so much, and we'll try and find something Vancouver-esque to send you in the meantime for your time today. That's it. Thank you.
Thank you all very much.
Bye-bye.
Wonderful to see you.
Thanks, Lisa.